Okay, again, we just want to thank everyone for your time today. We know it's a bit of a long day, and we value and appreciate your time, but we know that the feedback that you give is going to be important in helping us shape the future of precision health. I want to spend just a few moments recognizing our co-directors. They thank everybody. I think it's rare that they themselves get thanked. So I want to thank Jenna and Brahmaji and Sebastian for the great leadership and guidance you offer our initiative each day on top of all the other things you do. We thank you for your passion, your time, and your efforts. Again, I want to acknowledge the fantastic Precision Health staff that makes this thing go every day. They do it with great professionalism, strategy, and care, so I thank our staff team. I especially want to recognize Erica Lycan, who managed this program and put it all together. Erica is our new membership manager. I know that they've reached out to many of you, so you are all getting to know them, and we hope that our membership will continue to grow and just flourish under Erica, so thank you, Erica. And especially to our members. I know our session had a robust discussion. I'm sure the other sessions were fruitful, so we are very anxious to hear from you about those 3 questions and other thoughts you would like to share with us around precision health. As I mentioned, we hope that this is just a start of deeper engagement. We hope to have deeper discussions with you throughout the year, to get a chance to visit many of you in your departments, to share our work and our resources with your teams, and to hear from you whenever you want us to hear from you about what you think would be valuable for precision health. So with that, I want to offer Group 1 the chance to come summarize your discussion for us.
Hello, I'm Heidi Igler-Rieger. All right, so question number 1. We thought that what was missing across the matrix is to actually go back to, you had mentioned the triangle you originally had that said, hey, you know what? We want to talk about discovery, translation, and integration, implementation, whatever your verbs were. Instead of having that, we thought it was a little bit much. I like the detail, but that's just me. The example also was given that, you know, one of the questions we asked was kind of how do you advertise, right? Is what we discussed. One of the methods was when you go out and give presentations, tailor it to the specific audience, right? So an example was given, C. diff research. There's a certain clinical population that's going to be very interested in that, but some other groups maybe not so much. So just pick your stories and remind them of what it is we can do. One thing that came up several times with a few people though were that, you know, the people here mostly, we are like data nerds, if you will, right? We're the people who utilize these systems. But let's also reach out to others who maybe don't have that training, but have excellent ideas. Like we're talking about busy clinicians, and we don't just mean physicians, right? We mean everybody involved in clinical care. And so that this is really a multi-directional operation, if you will. Question number 2, we thought the complexity of getting data into a usable format. I mean, if we knew the answer to how to do that, right? I think that's a question a lot of us are asking, but that's one thing we thought would be helpful. Also to help people to find and share tools, because we have a lot of resources here, but we don't necessarily know what we have. It seems to be a bottleneck in getting towards some pragmatic trials. Examples were, hey, we have intervention A and intervention B, and we're going to randomly assign them and then see what happens. We don't really have the tools to do that quite yet. There are some much larger problems, if you will, that's where we're finding there's gaps in understanding. We also mentioned, of course, that always one way to facilitate is to educate our potential users in terms of this is what we have and how it can help you. We also discussed a bit about we are now integrating with a lot of other health systems, and so can we integrate the data side of it as well and the tools we have. And then number 3, basically our suggestion came down to a matchmaking website for Michigan researchers. No, we just want to make sure that we hook collaborators up together in a meaningful, intentional way. Because in one example they gave us, hey, you know what, when grants come in and we decide, not gonna fund it, but you know what? This is a good idea, and I'm gonna hook you up with this other person who can help you, and then you come back to us in 6 months, and let's talk again. Because earlier there were a lot of conversations about luck, right? I was lucky enough to sit next to that person. Well, we can help with that luck. So anybody from our group, are there key things that I missed? Now's your chance. No. All right.
I was stalling for them to be seated before I thanked 2 other people in the room, and they're back at their seats. So especially to Vicki Blank and Erin Kaliba, we talk a lot about our data set and MGI, and all of that work would be impossible without our support from the Central Biorepository and this tremendous leadership of Vicki. And Vicki doesn't just collect and monitor the samples, she helps us write and set policy and a number of other things, so we wanted to recognize Vicki. And of course, Erin and the tremendous team at Doctor. Don't make me say what the acronym stands for. It's been butchered 4 times today, so I'll spare you the 5th one. But the Doctor team does tremendous work at dealing with the data access, the data curation, just everything data, and we appreciate you. We can do our work without you. And with that, group 2, you're on the clock.
All right, my name is Krishna Rao. I'm an infectious diseases physician and scientist. I'm going to do my best to summarize the very robust discussion we had in group 2. So with regards to the first question, in terms of gaps in the framing, Akbar actually started off by challenging the premise of the question and the framing here to say, what we should do is we should say, what's the headline we want? And actually, maybe someone else had, this was your, Dr. Rosen question. So what's the headline that we want in the New York Times? So one example that I gave, just based on my own research, is what if at University of Michigan, when someone gets admitted, they get their microbiome profiled? And we use that to make clinical decisions, such as what antibiotics to expose or not expose to them to. Do we prophylax against C. difficile infection? Once they get C. difficile infection, can we use that to predict who's going to recur versus not recur, and adjudicate resources in a way that makes sense? So, with that in mind, one of the things that we thought was a gap was kind of real-time omics. That's not a University of Michigan specific gap. That's something that doesn't really exist right now. But a lot of groundwork has been done to try to understand what the microbiome associations are with various disease states and conditions. People even use these data to make predictions and validate those predictions in models. And some people are actually looking at the portability of this now, going from different studies across different sites. But how do we actually take that information and operationalize it? Well, we need something that can generate data in more than 96 well formats over the course of a week or 2, right? So sponsoring that kind of work is something that could be helpful. The other thing is there are real-time needs even for purely clinical models. So sepsis came to mind as something that is a lot more fast-moving than something like C. difficile in many situations, and where 1 hour can make a big difference in patient outcomes. And while there are ways to generate models using a limited number of variables, I'm told, even as frequently as every 15 minutes, if you wanted to run like our C. diff model, which uses 1,000 variables, that's not really something that can easily be done in real time. So that's a potential also a gap that could be addressed. There are data missing from Data Direct. And maybe this has changed over the years, but in the past, radiology reports, for example, weren't available there, and we had to request those separately from the data office. But there are also disparate data sets across the university and the health center that aren't really integrated right now. So the examples that came to mind would be the echocardiogram images. I don't think you can even get those in MyChart. Cardiology has its own database for that. The microbiology.
Soon you will.
Soon. Oh, there we go. All right. The microbiology laboratory, for example, going back to my field, in MyChart you can get a blood culture result that says positive or negative, but then there's this blob of text that comes afterward. And what I care about is what organisms were there, and I would love to have discrete entries and ways to pull that data. And the micro EMR or electronic system can do all of that, but it doesn't talk to MyChart in the same way that enables us as researchers to get access to that information. Maybe another example would be radiology. I think the images, for example, were something that is much harder to get access to using tools like DataDirect. And then I think there's some gaps too outside of the acute care setting. So in the rehabilitation x-axis there, a lot of our patients will be discharged not straight to home, but to some sort of subacute care facility, whether it's subacute rehab or a long-term care facility, a nursing home. And there's a lot of infection prevention and stewardship that happens there. There's a lot of transmission of pathogens and infections that happen there that then come back into the hospital. And I have colleagues that would love to get access to those communities and to those patient populations to better, more holistically model some of these things. Not that I have a concrete, immediate suggestion for how precision medicine can help with that, but there are stakeholders here, and people here who have that expertise in geriatrics. Lona Modi comes to mind as someone that we should maybe talk to about how did she establish these relationships? How can we make that more accessible to people other than her? Okay, going on to question 2, what additional resources, tools, and services would you want to facilitate your research? Multiple people brought up data scientists, access to data scientists. And so I know precision medicine has been thinking about or talking about hiring people like that, and certainly that seems to be a common need. We talked a little bit about integration of these kind of disparate data sets already. Having risk scores in DataDirect. So to give you an example, I'm contemplating doing a project on colon cancer with a gastroenterologist. And we are interested in people who do not yet have colon cancer, but then may be at risk for developing it. And how do you identify a cohort like that in DataDirect? And there may be models and very accurate, validated models that could be deployed in the DataDirect tool itself to help you enrich for that population that may have the outcome more frequently. And that could take a study that maybe has an infrequent outcome that you would need multiple sites to pull off, that if you enrich for that outcome, well, all of a sudden now you have a much higher frequency of your population having that outcome. You can power your study at a single site potentially. Akbar, I think, brought up this open science framework that sometimes it's not the question that's the problem. It's how do you actually go about answering that question? How do you go about getting the data? Do you do the IRB first, or do you approach DataDirect first? And these open science frameworks have been promoted where there's a DOI assigned for that entire process that's all documented from beginning to end that can help people figure out how to begin, essentially. There was some information about medication administration data too that someone brought up that was incomplete. I think it was Amy Pasternak brought up was somewhat incomplete, and it would be better to have that better access to that data. That's another data set or database that I think is disparate. Pharmacy still uses their own kind of a database. They used to use a program called Theradoc. I don't think that's in use anymore, but they have something else that's in use now. But again, it's separate from MyChart. Okay, and then moving on to the third question, what makes a multidisciplinary collaboration successful and suggestions for that? I think engaging clinicians is one thing that we talked a lot about, and concretely, basically every department/division has a business meeting. In our case, we meet once a month, and others may meet more frequently or less frequently. And we have all kinds of people come to those to give us presentations. We've had the endowment office come and give us a presentation. We've had risk management come and give us a presentation. We've had billing come and give us many presentations. That's very important, I'm told. But we haven't had Precision Med come and give us a talk and say, here's what we do, here's what we can help you with, and here's what we can enable. Pretty much any division is going to have 15 minutes that they can give you a minimum, if not more, at one of these meetings. And so I think that's one way to engage them. We also talked about the importance of engaging nurses and other non-physicians in this effort as well. And just concrete examples from what we do in the C. difficile work, which I'm told you heard about this morning, is we found that just going and talking to these folks in person has been incredibly helpful. They've given us feedback that we didn't think about. They've changed our intervention in ways that we frankly found a little bit embarrassing, that we didn't think about these things ahead of time. So that's one group that I wouldn't set aside. I would engage with them as well. And then there was a lot of talk about students too, but I don't have very good notes on that. I think that's the summary of what our discussion was. I'll let others chime in if there's anything I missed. if there's comments.
What's the latency for real-time data that you're talking about every day? 40
Well, I think it depends on what the task is, but in terms of making management decisions around sepsis, I mean, the 15 minutes sounds about right. Something like C. difficile, again, C. difficile can be a very fast-moving target. It's not always, but we've been able to get by and I think succeed in our efforts with once a day updates. All right, thanks.
Group 3, you're on the clock.
So my name is Rada Mihalcha. I'm a professor in computer science, also a Precision Health member. To relate to someone you know, I'm Jenna's colleague, so I'm like her, kind of. And I brought my little cheat sheet here to talk about our discussion. We had a very good discussion around the 3 questions. So first off, speaking about gaps, I see quite a bit of overlap between what was discussed in the other groups, which I think is good. There is convergence. So we talked about data synthesis and processing and how that would be relevant to others. So if somebody spends time to, say, map precision health data to some higher level concepts that are relevant to certain domain experts, making that available. So this kind of mapping would be useful. I also mentioned possibly having APIs. So a relevant question there would be how that would also connect to eHealth and what's happening there. We also, so that would be early on as a way of people to engage by providing, by identifying themselves as someone who does that kind of work. Also going to the other end of the spectrum, and I've also heard that from other tables, is assessment of impact and evaluation upon deployment. So that's something that would be useful and relevant, and some people could identify with that at their space. I'll point forward, we also discuss evaluating the data sets in precision health and how this kind of deployment could give some brownie points. So the fact that the data set was used in a way that went all the way to deployment, that could be something that will point to the value of that particular data set. The other thing that we talked about is adding other data sources. It was me bringing up language. I'm working in natural language processing. We use language all day long. I use language now. Doctors use language when they talk to patients. There is a lot of language in healthcare, so having more of that. Acknowledging that is very difficult because there is a lot of privacy involved, which is at some point hard to resolve, but I think that would be something else that would be interesting to add. And I realize Jenna mentioned prompt, so there are some projects underway that would have some language data, but thinking of it at scale. So for instance, as we speak, I'm sure there are some doctor-patient conversations that are happening. To what extent, at least a subset of those could be recorded. And then people also brought up there might be members who would be identifying with multiple points in that matrix that Jenna showed. So how to make the most out of those people who have multiple interests, would not necessarily fit in one place. And the other thing which we talked about is not necessarily a gap, but I thought it was interesting. It was brought up with respect to success of what precision health does. So one will be deployment. The other is just use. So how many people would use a data set aside from the people who actually created the data? So is their data reuse, and that would be a way of evaluating the data sets. In terms of the second questions, second question on what would be other things that would be useful, we talked about making data available across institutions. Again, with a lot of discussion on how that is difficult to do. I know we already have some success stories, and a lot of my examples come from Jenna. I know she used some of her tools across multiple hospitals. People can access precision health if they have collaborators here, but thinking of even higher scale. And Trinex was brought up as an example. I actually haven't heard of it before this discussion. Apparently it's a way of having access to data across multiple countries. So it goes both ways, how we could have access to data outside Michigan and how could others have access to the data that we have here as a way of leveraging even more what Precision Health has put together. And another example that came to mind was a hackathon that was organized some years back on top of Precision Health data. So having more of that, I think, will really get people to think about. There are a lot of students, junior researchers, who are very excited about having access to data, and they will come up with brilliant solutions to whatever problems we have. So opening up Precision Health to others through hackathons, for instance, would be a way of just getting people to think more about that. And finally, for the third question on what makes successful collaborations and how Precision Health can facilitate more of that, we talked about facilitating more conversations, like the ones we just had. People really seem to enjoy themselves between methodologies and clinicians. One idea that was discussed is having workshops on specific topics. So this today is Precision Health broadly, for a good purpose, celebrating 5 years, but picking some niche topic. So having maybe 10, 15 people on a particular topic and discussing. I know Midas is doing that successfully, sometimes connected to funding opportunities. There was also somebody who's semi-volunteer, and since he's gone, we can fully volunteer him. Vinod Vidisvaran mentioned the de-identification of electronic health records as an interesting problem where there are multiple people on campus who are interested in that. So that could be like a focused discussion, not necessarily tied to a funding opportunity, but those will eventually come down the road. And that will be another way of facilitating these conversations. Another idea was to showcase existing successful collaborations. We've been hearing about some of those. There are some shared in the newsletter, but maybe doing more of that so people know how that works and how is it done. And finally, it was this idea of helping with that shared language, acknowledging that different disciplines have different languages. Not necessarily we all speak English or we think we speak English, but there will be different terminologies. So having that facilitation, that would help in new collaborations. And for instance, as a first step, somebody on the scientific team of Precision Health could help with that, serving as a bridge, maybe participating in some of the initial conversations, being very familiar with what Precision Health has to offer in terms of data, for instance. And so facilitating that conversations with deep knowledge of Precision Health. And down the line, maybe thinking of APIs, so tools that would provide that kind of access to what Precision Health has to offer, which would facilitate it. So we'll have a shared knowledge, would be something that everybody talks about. Say, when we talk about diabetes, everybody talks about these particular attributes, and so that will be available. And that's all. Thank you.
Thanks, groups. That was awesome. Great feedback for us to work with. Before we close, are there any final statements, comments, or questions that didn't come out in the summaries that anyone would like to share? Final thoughts, really smart thoughts you think we need to hear? Going once. We have one from Mike.
So I just wonder, you got all this great feedback and strategic planning ideas. Like, how will you operationalize your next step?
Absolutely. So we're going to go back and get these summaries. We're then going to take it to our next level of leadership, which is our work group leaders. We're going to start discussing this with them in more detail as they oversee our overall daily operations and our specific work areas. And we're going to build from there. Like I said, we hope this is the beginning of deeper engagement and just not a one-hit conversation with all of you. And so, especially you, Mike, who do so much for, especially around our imaging work, we'll be in constant conversation with you as well. Any other questions? Dan?
So I'm all for more omics and immediate omics or real-time omics, but I would just reiterate the point from earlier today that we already have clinically actionable genomics, that we haven't found the right ways to actually implement in patient care. We have things that we could immediately do to help patients using our existing genetic data. And I'd really like to see some focused action on figuring out how we take our existing genomic data, make sure it is being used to make clinically actionable decisions that can improve patient outcomes.
Thanks, Dan. Great point. Other thoughts or comments? Well, again, thank you. We look forward to talking to you further or seeing you at our next program. Thank you. Have a great day.